muscles, or sometimes children are born with problems with the eyelids. Those are all reasons why reconstructive surgery or eyelid surgery may be considered reconstructive in nature and not purely cosmetic in nature, and hence it's ethical and perfectly fine for us to ask an insurance company to get involved. So let's start with the upper lids and eyebrows. Before I go further, I want to remind you that analysis, preoperative analysis during the consultation and in photographs or using our Vectra computer imager, that's a vital, very important part of the analysis preoperatively before going to the operating room for the eyelid and also any part of the body. Preparation is very key. Analysis is very key. So what about reconstructive surgery for the eyebrows and upper eyelids? I think the most common reason why I see reconstructive surgery problems around the eyelids or eyebrows or forehead or upper cheeks is based on removal of skin cancers. As you know, skin cancer is increased in people who have a lot of sun exposure, the ultraviolet rays, even though it feels good to bake in the sun and lay in the sun and go to the beach, etc. The UV rays result in degeneration. They can result in genetic changes. Basal cell skin cancer is very, very common. Squamous cell skin cancer is common. Melanoma is also increased in people who have an increased incidence in heavy sun exposure or sunburns before adolescent time. So oftentimes I will see people who have a skin cancer of the eyelid or upper cheek or forehead, eyebrow, the glabellar area that's just in between the eyebrows, and the dermatologist will ask me to remove that skin cancer, or the Mohs surgeon, the Mohs chemosurgeon or dermatologist will actually remove the skin cancer, and there will be a defect, and that doctor and patient will ask, the plastic surgeon will ask me to reconstruct it. And there are various techniques that we use to reconstruct the periorbital area. I want to use two descriptive terms to teach you in broad terms to give you an idea of a couple of different ways how and why we would reconstruct the periorbital area. A local flap is when we transpose adjacent tissue into a defect, into a hole. For example, if there is a defect from a skin cancer of the eyebrow and the lower forehead, if we can design some tissue from nearby to slide in or transpose or lay in into that area, and a portion of it is still attached to the body, that's a local flap. There's something called a rhomboid flap that I use a lot. There are bilobe flaps I like, mustard A, cheek advancement flaps, all types of different flaps. And what that means is typically full thickness skin is transposed or moved in to fill a defect. Now, there will be a scar around the defect, of course, because there was an incision made, and hence there'll be a scar resulting. And there will oftentimes be a scar where we took the tissue from. There'll be a donor site scar. And so we try to hide those scars. There are different ways we devise, and we can calculate the closing angle, for example, of a rhomboid flap and transpose tissue in to fill a defect. That's called a local flap. Now, a graft is when we take tissue from the body and we totally separate it from the body. We pick it up and we plant it somewhere else. For example, a skin cancer that leaves a defect, let's say in the lower lid. One of the better ways to reconstruct the lower lid is if someone has extra skin behind their ear, or even if they have extra skin in the upper lid. We can remove extra skin from one part of the body, we can close that area up, and we can take that skin and use it as a patch. It's almost like taking a seed, an apple seed, and we remove it from the apple, we can take it out of the bag, we can toss it into the soil, and as long as it's properly cared for, properly watered and fertilized, etc. Same way we can take care of a graft. Oftentimes it will live. That's where most of the time it will live if done properly. So a local flap is when we move adjacent tissue around to fill a defect. A skin graft or even cartilage graft or bone graft is when we take a piece of tissue from the body, we pick it up, totally separate it from the body, we sew up the defect, and we use that skin, for example, to patch the lower eyelid or the upper eyelid or the forehead, any area around the eyes, the cheek, or almost anywhere in the body. Oftentimes a skin graft will be a very effective, straightforward, relatively simple way to patch. Now, it's not always an ideal way. Sometimes we lean towards a flap because of the color match, the thickness maybe. Thickness of the tissue missing may be better served by replacing it with thicker tissue, thicker like tissue. But a skin graft, for example, will be probably thinner. There may always be kind of a patch appearance, a patchwork or quilting appearance. But there's pros and cons to each decision. Depends on the size of the defect. Can we devise a flap to fill in a defect? Is it more simple to do a skin graft? Does a person mind a patch look, etc.? There are certain parts of the body where someone has a defect and it's not going to show anyway, and so we just want to get it closed up and get a person out of the hospital or back to their life or back to the golf course, etc. quickly. And so oftentimes a skin graft will do very well, but oftentimes we will want to flap. It really depends. Each person needs to be analyzed, and we need to look at the options and undergo a custom designed approach for that person. Now, before we go on, I want to complicate matters a little bit and talk about something that's called a living graft or free tissue transfer, a microsurgical flap. There are certain times when we need very complicated tissue. Let's say I need to cover a tendon that's exposed, or I need to transpose a muscle, or I need to transpose so much bone that I want the bone to have its own blood supply, or a tendon. Let's say that I need a small piece of tendon to be replaced. I can take a graft, pick it up, totally sew up or the defect and replace it. That's a free graft. But in these instances where we need complex tissue and it will not survive on its own, we will oftentimes do a microsurgical flap. That was at first, when we first started doing these, they were called living grafts. We dissect the tissue, that complex tissue, we take the artery and the vein accompanying and supplying and draining that tissue, we isolate it, dissect it free, we pick that tissue up, put it somewhere else, and we actually hook up the artery and the vein under the microscope, because all tissue needs blood supply. Blood supply needs to flow in, and blood supply needs to get out. So that's called a free tissue transfer or microsurgery transfer. So those are a lot of words, probably about one of the most common reasons why I see reconstructive eyelid surgery in my office. Another reason for reconstructive eyelid surgery, say for the eyebrows, is for ptosis. Sometimes the eyebrows can ride so low, they can come down so low that it almost pushes down the eyelid, and it can actually result in visual field obstruction. What is visual field obstruction? A visual field obstruction is a broad term that describes any phenomena that actually obstructs the light, obstructs the vision, obstructs your field, obstructs the light coming in of a reflected object from actually getting into the eyeball. That can be if your eyebrows come down so low, it can obstruct the vision. There's another instance called lash ptosis, where the upper lids can get so redundant, so heavy, that they actually sit down and lay on the eyelashes. That's called lash ptosis. That can be a type of visual field obstruction. What that means is your field of vision is decreased. Typically, if you have your eyes wide open, you have a big field of vision. You can see up and down and to the sides, etc. If you have a visual field obstruction, that's when the eyebrow comes down so low, or the eyelid is so redundant and comes down so low, it lays upon the lash, and that's called lash ptosis. That's another visual field obstruction. There's another type of ptosis called true ptosis, where the actual lid margin rests to a low point that obstructs images and light coming into the pupil. That's called true ptosis. Lash ptosis, as I said, is when the upper eyelid is so redundant or so loose or floppy or extra that it rests upon the lashes. True ptosis is where the eyelid margin rests at a low point, and hence it obstructs the visual field, obstructs light from coming into the body. Now, children can be born with that. Adults can develop that. It can come after trauma. It can come after retractors for a cataract operation are inserted. It can come something called senile ptosis, where the levator aponeurosis just gets stretched out. So there are different reasons for people to have visual field obstruction or ptosis, but they all revolve around a mechanical obstruction to the light coming in, to the image coming in through the pupil, so the retina can recognize it. What about the lower eyelid? Well, the lower eyelid doesn't move a lot, but it serves as a type of dam. It serves as a type of dam to maintain moisture barrier, to protect the cornea, protect the lower eyelid. Now, when that barrier function becomes incompetent, a couple different things can happen. A patient can develop an entropion. That's when the lower eyelid rolls in, and that can be very aggravating because that can lead to trichiasis, where the actual eyelashes can rub and irritate the cornea and irritate the eyeball. The other more common instance is called ectropion. That's where there's some eyelid droop, where the lower eyelid does not serve as a proper moisture barrier, does not protect the globe so well. And that can happen with time. That can happen as we lose fat in the upper cheeks. That can happen sometimes after surgery. I see it frequently for lower eyelid surgery. Although it's temporary, it can last for a few weeks to a few months. With proper massage and stretching out the scar, almost always I see that ectropion after surgery resolving. There are certain instances after some skin cancers, or if someone has an overly stretched out support system, the lateral canthus can get stretched out, where someone can be helped by a canthoplasty or canthopexy. There's another method whereby we do a horizontal shortening. We can replace or reconstruct the support system for the lower lid. We can sometimes do a cartilage graft. We can sometimes do a hard palate graft, where we add tissue, add some mechanical support to a lower eyelid. So there's many different ways we can treat an ectropion that is resulting in very dry eye or irritated eyeball. After surgery, typically it's a temporary phenomena. If someone has an ectropion following removal of a skin cancer and reconstruction, or just from what we call senile ectropion, where the tissue gets stretched out with time and loses its resilience. If someone loses the integrity of the lateral canthus or even medial canthus, people can develop ectropion, and that can be corrected surgically. So again, for reconstructive eyelid surgery, it's really mandatory. The standard of care is to undergo a careful exam, careful history. We analyze the problem and go into our bag of tricks to deliver to the patient a custom designed approach. If you would like any information on any type of eyelid surgery, whether it's cosmetic or aesthetic or reconstructive, I hope you'll call my office here in Monterey, California, 831-646-8661, or go to my website, drmorwood.com. That's DRMORWOOD. Once again, I'm Dr. David Morwood. I'm a board-certified plastic surgeon here in beautiful Monterey, California. We're going to take a very brief pause for a very good cause. Hello, I'm Dr. David Morwood. I have over 25 years experience in plastic surgery. Here in California, we all love the outdoors. Golf, tennis, going to the beach. However, the sun can play havoc with the delicate skin on the back of the hands and neck. Call or click today to learn the newest methods for restoration and beautification of the hands, neck, and other areas affected by the sun. Hello, I'm Dr. David Morwood. I have over 25 years experience in plastic surgery. One of the common goals I share with my patients is that they look natural after their facial rejuvenation.
Dr. Morwood made me feel really comfortable. His staff is phenomenal. Going into his office is always a great experience.
Call or click today to learn how our combined approach of art and science can enhance your natural beauty. Hello, I'm Dr. David Morwood. I have over 25 years experience in plastic surgery. A smooth, firm neckline is a universal sign of beauty in both women and men.
Dr. Morwood not only helped me regain my confidence, he helped me achieve the best version of me.
Call or click today to learn how the natural neck lift can rejuvenate your beautiful neck and jawline. Welcome back to the Doctor Is In television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon here on the beautiful central coast of California. Thank you very much for joining me. What I'd like to do in the next few minutes during this segment is talk about operating overseas. These missions that many plastic surgeons go on, that I've been going on for years, primarily to developing countries, primarily to do cleft lip repairs and cleft palate repairs. Sometimes we do burned hands and burned feet and simple tumors and burn scar contractures, etc. I'd like to talk a little bit about this for a few moments. Just a few weeks ago, I went to Cuba with an organization called Plásticos. We worked with the doctors and nurses there in Cienfuegos. That's on the southern coast in Cuba. We're broadcasting now. This is June of 2018. I was there just a few weeks ago. And as you know, a few months ago, there were some very harsh, very terrible hurricanes that blew through the Caribbean. Puerto Rico lost a lot of power. A lot of buildings were blown down in St. Thomas and all over the Caribbean. And it really played havoc with many parts of the infrastructure. Electricity played havoc with many parts of the medical system in many of these island countries. And so we went down to Cuba with Plásticos to work with the doctors and nurses there, to do a lot of information sharing, to work together and help the kids with cleft lips and palates and burns. Oftentimes when I say to people, we're going to Cuba or we went to Cuba to help the children and operate on the children with cleft lip and cleft palate or burned feet or burned hands, they're somewhat surprised because they think that Cuba has an excellent medical care system. I think the medical care in Cuba is good. We did a lot of information sharing. We worked together. We had some conferences where we trade tips. Almost every day I worked in Cuba, there was some Cuban nurses or a Cuban doctor with me. And so it was a really valuable experience. I found the people there to be very hospitable. We stayed in sort of like hostels, bed and breakfast places. Our team with Plásticos, based in Newport, based in Southern California, it was a small team, about 12 people. Dr. Larry Nichter is the medical director of that program. We went with Dr. John Persing. He's the chief of plastic surgery at Yale, actually from Vermont, my home state. So the 3 plastic surgeons and a few volunteer nurses, we went down to Cienfuegos, Cuba, and the people were very hospitable, very friendly, very happy to have us there, and we worked with them. We stayed in hostels, about 4 or 5 different sort of bed and breakfast areas in this one section, and we worked at a children's hospital associated with a university. We almost got rained out because Tropical Storm Alberto blew through, and they got about 14 inches of rain in about a day and a half. It washed out part of the road from the airport to the hospital. It flooded the hospital. So we were delayed working for about 2 days. But then we, as in other countries, we held an opening clinic and we triaged the patients, and we met with the doctors and nurses there to discuss cases, and we lined up the cases and went to work. Then we had a closing clinic. And so I think it was really a good opportunity to work with doctors and nurses in another country. In a few weeks, I'm going to the country of Myanmar in Southeast Asia. It used to be Burma. There we intend to do primarily cleft lips and cleft palates. I'm certain we'll do some burns. Typically what happens with these programs, as I mentioned, I went to Cuba a few weeks ago with Plásticos. I'm going to Myanmar with Rotoplast, and then I'm coming home, and then I'm going to Guatemala. I go with Rotoplast, and I go with Alliance for Smiles. These are similar projects, similar missions, whereby they're supported by donations. No one gets paid to go. They're supported by donations, supported by the Rotary Club, supported by other charity organizations, by donations from individuals. And so what typically happens is we'll go to a host country. For example, I've been to Chile many times, and Venezuela and Argentina and El Salvador, and as I said, I'm going to Guatemala. I've been to China a few times, and South Vietnam. I've been to Africa, West Africa. So typically what happens is we spread the word to the pediatricians in a country or a certain state or region of the country. The Rotary Club helps with this because the Rotary Clubs can help to spread the word. And we spread the word and we say that the American team sponsored by Alliance for Smiles or Rotary or Plasticos will be at a certain town on a certain day. And if you have a child with an unrepaired cleft lip or palate, or you think they need speech surgery, or you think they need a revision, or they have a burned hand, or scarred up from a burn, a hand that's scarred up from a burn, or burned feet, report to a clinic in a certain town that we specify on a certain day. And we do what we call triage. We work with the doctors and nurses there, and we examine the children, we talk to the parents, we take a medical history, and typically we sort out or triage about 100 children for a mission. Oftentimes, for example, in China, over 200 families showed up with their children with unrepaired cleft lips and palates. In South Vietnam, there were big numbers of children with unrepaired cleft lips and palates. And so we can triage. There are certain cases where we feel it's best served by the plastic surgeons or doctors and nurses there, and they can handle that. There are certain cases where the children probably would need an intensive care unit after an operation, or if they have complex medical problems, and we don't think it's entirely safe to operate on them. And so sometimes we are able to get those kids transported to another country, like back to the United States, or to Europe, or to Japan, to a country that perhaps is more technologically advanced and has an ICU, intensive care unit, and we can help a child get the surgery we need that way. But typically, for one of these missions, if we operate for 9 or 10 days, we try to do 100 children or 100 operations. So we sort them out and triage them, cleft lips, cleft palates. Sometimes we do simple tumors. Sometimes we do scar contracture releases from burns of the hands or feet. And we start in the operating rooms that they let us use early in the morning. We start about 7 or 7:30. We oftentimes will do 4 or 5 operations each room for each surgeon. If we have 3 rooms going, we can have 3 surgeons working. We have anesthesiologists who are volunteers who work with the host country anesthesiologists, and we get to work. We bring nurses, operating room nurses and recovery room nurses and preoperative nurses. Oftentimes we will bring volunteers because there's lots of work to do. The Rotary Club is really good at assigning volunteers to these programs. We will have perhaps a non-medical person who learns how to do instrument washing, instrument sterilization and preparation. There's always what we call a sergeant at arms, where someone is in charge of the equipment. We typically bring, I would say, tons of equipment. We bring in pallets, and we bring in chests and boxes and duffel bags full of equipment. We'll bring an autoclave or more than one autoclave. We'll oftentimes bring in an anesthesia machine, 1 or 2, if we can't borrow them there. We bring surgical instruments. We bring sutures. We bring bandages. Oftentimes we will bring t-shirts or stuffed animals to give to the kids. So there's a lot to do. We have transport people. We have volunteers to help us get through customs. We have volunteers to help feed the kids. We have volunteers to help arrange for places for the medical workers to stay. We need volunteers for the medical people to get transport from the dormitory where we're staying in town, or the hostel, or the bed and breakfast to the hospital and back. So we'll need volunteers. There's a lot of work to do for these trips. It's a mission, and it's almost like we're waging peace. So it's a big movement. It's just not one or two doctors or one or two nurses going to another country. So as I said, the Rotary Club or Plasticos or Alliance for Smiles will spread the word that the American team will be at a certain town, at a clinic on a certain day, and we spread that word to the pediatricians. If you have a child, say, with a burn scar contracture of the hand or an unrepaired cleft lip and palate, be at that clinic on a certain day, and the child will be examined and triaged and sorted out, and we try to do as many operations as we can. In many of these countries, the travel is somewhat difficult and unpredictable. There's oftentimes kind of a second wave of children that arrives on the second day we're there, or even third day we're there. And so one of the surgeons will have to leave the operating room to go back to the clinic to see the second wave of children that has arrived with an unrepaired cleft lip or palate. Maybe their bus got delayed, or they had to hitchhike, or they didn't hear about it right away, or there was a media story. They saw the program on television that the American team is here doing cleft lips and palates for free, repairing cleft lips and palates for free. And hence, there'll be a second wave. So we operate for 8 or 9 days, and then there's a closing clinic where we see children afterwards. We can sign children out to the local pediatricians, or take out sutures ourselves, or give further instructions. It's very rewarding to go back to a town more than once. I've been to certain towns like La Serena in Chile, or Barquisimeto in Venezuela. I'm going back to El Salvador one day. It's very rewarding to go back to a certain place and get to see follow-up, because let's say that one year we do a children's cleft lip repair. We may be able to do the cleft palate the next year. We may be able to do a touch-up for them. Or let's say they have a burned hand, all scarred up. We may be able to do a scar contracture release and revision the next year and improve things. And so there's oftentimes a need to do more than one operation for a child. For example, even in the United States, where we still see, of course, cleft lip and cleft palate, this is a congenital difference that children are born with. Oftentimes, I would say, if a child is born with a cleft lip and cleft palate in this country, they will likely get about 5 operations between the age of 3 months and, say, 16 years old. We'll do the cleft lip. We will likely do a bone graft to the alveolus where the teeth erupt from. We'll do the cleft palate repair. We may do a rhinoplasty. We may do an osteotomy. We may do some speech surgery. We may do that osteotomy to the upper jaw or the maxilla to move it into better position. Sometimes people say to me they're surprised that there's cleft lip or palate found in the United States. There is cleft lip and cleft palate found in the United States. It occurs, but what happens here is that most of those children, most of those babies, get their operation at an early age. So for example, here in Monterey, you don't see children with an unrepaired cleft lip walking down Alvarado Street, whereas in another country, in Caracas or in Buenos Aires, you might see a child with a bandana covering a cleft lip. You might see we see children who have never had a cleft palate repair. On occasion, we'll see an adult with an unrepaired cleft lip or unrepaired palate in these countries. It's because they don't get the care that they do here. And so it happens in the United States. It does. The most common incidence of cleft lip and cleft palate is outside of Shanghai, China. About 1 out of every 250 babies born there has a cleft. The second most common incidence is on the western part of South America. About 1 out of 400 children is born with a cleft there. In Europeans, Caucasians, North